Thank you,
The
sir.
next topic is ileal pouch anal anastomosis and the problems. Well, the most common indications of the procedure are chronic ulcerative colitis that cannot be controlled by medication, and for patients with familial adenomatosis polyposis. Uh, we do not definitely do it in Crohn's. It is typically done in 2 stages to allow for pouch healing and for its adaptation, and to mitigate the risks of complications of a pouch anal anastomosis, particularly the leaks. Sometimes we even do in 3 stages when you're operating in acute colitis. Like many of the standard procedures, there may be a debate on a single or a 2 stage procedure, and we have Deeksha Kapoor here waiting to address this problem and give a balanced view of the solution, possibly with her own tricks to avoid the problems and selection of patients with an analysis of merits and demerits.
Thank you, sir.
Deeksha is one of the young but very energetic and enthusiastic and rare breed of a few female members of our group. And I caught hold of her in, I think, one of the Jaipur surgical tutorial sessions. And she has contributed to some of the sessions earlier. And she was till recently at the Medanta, but I think a couple of months ago you have moved to BLK, is it?
Yes, sir. Just about a month.
Yes. Okay. Go ahead.
Thank you, sir. So thank you so much, Professor Sastry and Professor Kapoor, for a very generous introduction. And I'm really grateful to be a part of this group. And we are having some great academically oriented discussions. And I really hope that it benefits the students. I'm sure to say that having to read for this has benefited me. So we are talking right now about ileal pouch anal anastomosis. Does it make sense to do it in a single stage versus a 2-stage procedure, and possibly when? So like sir already said, that we are going to do this procedure most oftenly for a diseased colon, and the most common recommendation for this would be an ulcerative colitis followed by FAP. Very unlikely that a single stage pouch, or even for that matter, the percentage of a restorative proctocolectomy being done for a Crohn's disease is relatively less. Whenever we are operating in a semi-emergent or emergent setting, we end up doing a subtotal colectomy, and that leaves us open with the option of either proceeding with a 3-stage procedure, that is a subtotal colectomy followed by a completion proctectomy, a pouch, a stoma followed by stoma closure, or a subtotal colectomy followed by a completion proctectomy and pouch without a stoma. So we can have an option of a 3-stage or a modified 2-stage. But other ways to look at it is whether we are looking at 3-stage, 2-stage, or a 1-stage procedure. 1-stage procedure being the most uncommon kind of staging that's done. This is often the diagram which is shown on most website, academic windows, and textbooks, which is a very simplistic view of how a pouch is constructed. So for all of us who've actually done it or seen one, whenever we make the pouch, the mesentery of the small bowel is tethered posteriorly and inferiorly, and the room of movement for the bowel actually goes down. And the bowel is actually twisted a little bit to make or mature a stoma or an ileostomy in the right iliac fossa. So there are 2 things I want to point out over here. One is that the mesentery is fixed now, the room of movement is less, and to be able to make a stoma well enough, we end up moving a little more proximal than the traditional 20, 25, 30 centimeters from the pouch, so that it comes out comfortably and we are able to close it comfortably whenever we move forward for a closure. So this is a real life scenario, and this is not something that's written in textbooks, but this is what I feel actually happens. There are certain problems with a divergent stoma. So stoma-related obstruction, which can happen exactly for this reason, that the stoma has not been matured properly. There is a king proximally, the proximal limb gets adhered to the anterior abdominal wall, the incidence of which is anything between 6 to 25% reported in various series. Stoma diarrhea, we of course understand it is possibly perceived to be a little more with a pouch patient than in another setting of an LAR and an ileostomy, simply because we are losing about 40-50 centimeters of bowel furthermore before we are able to mature a diversion. So the incidence being 14 to 25%, it is one of the most common causes of readmission following a pouch surgery. And needless to say that the dyselectrolytemia and the dehydration has a physiological and a financial toll on the patient. Following closure of the stoma, the incidence of small bowel obstruction, which is the most commonly and the most important trigger why a single stage pouch procedure was propagated, can be as high as 1 in 5 patients. Again, it is perceived to be a little more common in a patient who has undergone a pouch versus an LAR and stoma closure. It's been since 1978. This is probably one of the first series that was published by Professor Parks and Professor Nicholas of proctocolectomy without an ileostomy for ulcerative colitis, in which they showed technical success in 4 out of 5 patients, along with no complications. So the attempt to actually avoid a stoma is not something new. But can really the stoma be avoided is the question. So like I said, that let's leave the 3-stage behind. Whenever we are looking at 2-stage, we are looking at 2 ways at it. So the typical 2-stage is a restorative proctocolectomy with a stoma followed by a stoma closure, versus a modified 2-stage, which is a subtotal colectomy followed by a completion proctectomy and a pouch and no stoma over there, and a single stage, which is a restorative proctocolectomy. So in 2019, in JAMA Surgery, this retrospective study was published, which actually stated that the 3-stage procedure is probably overused for acute ulcerative colitis. And they said that one of the most important reasons that actually decrease the complications in a 2-stage procedure is the surgeon experience. And by multivariate analysis, the only thing that made a difference in postoperative complications. So whenever we are looking at downstaging a pouch procedure, we must understand what's relevant in which patient, what advantages do we get out of it, and what are the possible disadvantages to it. So this is a meta-analysis of 10 studies, about 1,700 patients, in which they said that the modified 2-stage versus a 2 or the 3-stage was equivalent in terms of anastomotic leaks, pouchitis, ileus, and small bowel obstruction. But whenever we are talking about studies or retrospective data in ulcerative colitis, one of the things we must be very observant of is the use of biologics. I understand that this systematic review is a comparison of 2-stage versus 3-stage and not 2-stage versus 1-stage. But I want to draw a certain point over here. So when they excluded patients or series in which the use of biologics was more than 20% was in more than 20% of the patients, both the procedures behaved equivalently. So the complications of a modified 2-stage actually decreased. So in patients with no biologics, it was actually okay to avoid a stoma. This was the meta-analysis figure in which it says that in pediatric patients, it favors a typical or a traditional restorative proctocolectomy and a pouch, that is, do not avoid a diversion stoma. Whereas in adults and in patients, basically in series in which the percentage use of biologics was less than 20%, a diversion could be avoided. So if we have to extrapolate this, in patients in whom biologics are not being used, possibly a diversion can be avoided. So this is another retrospective analysis which looked at 2-stage versus 3-stage, in which the total number was 212, and it said something very obvious, that the stage 3 is likely in all emergent settings, and there was no difference in perioperative complications, anastomotic leaks, pouchitis, or pouch failures in 2-stage versus 3-stage procedures. But let's understand why we want to avoid a divergent stoma. So there are some surgeons or some groups who will support the presence of a diversion stoma with the pouch. That is, if you do a stoma, you avoid a major morbidity. The consequence of an anastomotic failure or an anastomotic leak decreases. This was very well covered by Dr. Vashne. The anal sphincter is allowed to recover after a fresh surgery. So that is also supposedly beneficial. And one of the very important factors which I feel is relevant is that there is a psychological benefit of living with the stoma for some time before reversal. We must understand this is a quality of life surgery, and we are doing it for a disease in which anyway the patient is passing stools between 8 to 10 times per day. And even after the surgery, it's not that the incidence goes down a lot, but the psychological benefit of getting rid of the stoma actually supposedly makes the quality of life better for the patient. Then there are certain groups of surgeons who oppose a diverting loop ileostomy, stating that there is a reduction in the length of hospital stay, and the immediate use of an anal sphincter may actually avoid the development of a sphincter disuse atrophy. They also propose the evidence for this is questionable, that the risk of pouch ischemia is reduced. A proximal stoma will compromise the blood supply from a pouch. The problems of diversion ileitis may also be avoided, and the issues of small bowel obstruction post a diversion loop ileostomy closure are also circumvented. So is it actually possible to move away from a diversion stoma? This is possibly the most important evidence of literature that I want to emphasize on during this presentation. This is a recent meta-analysis published in 2023 in the Journal of Crohn's and Colitis, which looked at the data from 20 studies with a total number of patients 4,500, about half of which had not received a diverting ileostomy. So they said that when it comes to pelvic sepsis, if we look at the entire cohort, the forest plot, the diamond actually shifts in favor of a diversion loop ileostomy. So this shift was actually statistically significant. Similarly, with the rate of reoperations. So in patients with chronic ulcerative colitis undergoing pouch surgery, if there is no diversion, the chances of pelvic sepsis and the chances of a reoperation go up. But does that actually result in increased incidence of pouchitis or pouch excision, which is the traditional teaching? And it said no. The incidence of pouchitis or pouch excision did not go up even if the patient developed pelvic sepsis because a diversion stoma was not created. But the overall morbidity was not increased, nor was the rate of anastomotic leaks. So this was not found statistically significant on this meta-analysis. But there was a benefit in the rate of bowel obstruction in the long-term outcomes and a benefit in the incidence of anastomotic strictures in the long-term outcomes. Similar data was demonstrated in another meta-analysis which looked at data of only pediatric patients in a pouch with a stoma versus no stoma. And they said that the rate of leaks, pouchitis, small bowel obstruction were all similar. But the one fallacy in this was that the total cohort was 800 and the undiverted patients was actually very small, only 17%. Now, with ulcerative colitis, of course, we know that the bowel is diseased, but for a FAP patient, it's a polyposis bowel. It's not an inflamed bowel. So is it possible to actually do it in one stage? In this particular study, which is one of the large series of pediatric patients undergoing a pouch for FAP, it said that if the stoma was not made, it was associated with an increased risk of anastomotic leak and reoperations. But whenever we look at the data for a pouch surgery, we must realize that most of these series are retrospective studies, and most of these are single-center data. In the meta-analysis that I showed from Journal of Crohn's and Colitis, which quoted data of 20 studies, about 16 of them were retrospective studies and 4 being prospective. Because of this, there is a huge selection bias. I guess everybody will agree that in a patient who is on a high dose of steroid or who has received biologics, one will err on the side of making a diversion stoma. Also, most of these studies come from high volume centers and not centers that are doing pouch surgeries on a yearly basis under 10. So although we do discuss about the learning curve and high volume concept when it comes to HPB surgery, for a surgery which is no less complicated like a pouch procedure, we don't know what the correct volume should be so that the rate of complications go down. This is my last slide, and I just want to derive in the message that I personally will err on the side of doing a diversion stoma at least for the next few years in my career. And if at all a seasoned surgeon is considering a single stage pouch, the absolute must should be that the procedure be done by a high volume surgeon in a motivated and counseled patient. The patient must understand what he's getting into, what are the possible consequences of the surgery and of the complications. The patient should not have been on biologicals before the surgery. It should be done in an elective setting. The surgery per se should be uneventful with complete donuts. In case during surgery, the surgeon is uncomfortable or there has been an unexpected event, one should err on the side of doing a diversion stoma. One may consider a single stage procedure if the mesentery is really fatty and the pannus is really thick and the patient is obese, because in that case, it is virtually impossible to bring the stoma out to the level of the skin. That is probably one of the few areas where one would take the chance in avoiding a diversion stoma. Additionally, there should not be any adverse factors that would actually give more weightage to performing a 3-stage procedure rather than a 2-stage procedure. So if you cannot really bring out a ileostomy following a pouch, maybe do an end ileostomy and stage it as a 3-stage procedure rather than doing it as a 1-stage. I would never recommend a single stage procedure by somebody who has limited experience. In a patient who is poorly selected, it's not a decision which is made on table just by the whims of it that let's do a pouch without a diversion stoma. A procedure in which the surgeon has been uncomfortable and there have been some inadvertent events or unforeseen circumstances. And I think we all would agree that in a surgery like this, it is never sensible to please an adamant patient who demands that a diversion stoma not be done. Thank you.
Thank you, Dr. Deeksha.
Thank you, sir.
Good, wonderful exposition of pros and cons and the final conclusion, your own personal, but I think it applies to all. Although you did hint about single stage or 2 stages for FAP versus ulcerative colitis, you didn't include it in the last slide. Maybe in that middle, you may consider, in an ideal circumstances, when you're doing for an FAP, you may consider avoiding ileostomy. Would you agree with that?
Yes. I agree, sir. I agree with that. But sir, I would also say that in extension to the comments you made after the previous previous presentation, I think at least for the next few years, I will always do a stoma. And I wouldn't recommend obviation of a stoma just because we are discussing this and just because there is a meta-analysis that says that it's okay to do it. I just want to include to what was said in the previous presentation, we often take a low anterior resection as a not so major or a not so serious operation. The anatomy, the vascular anatomy of the left colon, whether the IMA has been divided at the base or not, what is happening with the left colic artery, whether the blood supply is adequate or not, what extent of lymphadenectomy has been done, it's been done by whom. The rectum has been divided in 1 stapler or 2 staplers. I think a lot of these soft points, which cannot be actually given a number to, these intangibles are very important while making a decision whether a diversion can be avoided or not. So I think that same applies to something like a pouch. Unless it's absolutely, absolutely smooth, I think one should err on the side of doing a diversion.
As you are there?
I think I have no confusion regarding the management of the surgical management of a polyposis coli, where we are not definitely going to do a 3-stage procedure anyway. So the confusion is, the debate is the management of ulcerative colitis, even not in malignancies. So ulcerative colitis, we tried to look at the results of the 3 steps through our thesis projects. We started with comparison of 3 stays versus 2 stays. And first 3 patients of 3 stays, single stays versus 2 stays. First 3 patients of first 3 stages, all 3 of them leaked and they went into sepsis. And 2 of them we have not been able to do anything till now. So we abandoned that. Then we continued it, the second stage as a prospective study, and we found in 60-70% of cases, 60+% of cases, there was pelvic sepsis, leak, and so we also abandoned that one. Now we moved to modified 2-stage procedure. I think the advantage here is you are taking care of the disease in the first stage, then you give a gap where you are not giving any steroid or any immunosuppressants during that period. And I strongly believe that if you look into all these events, most probably in Indian scenarios, in our scenarios, the patients are taking steroid for a very, very long procedure, for a long period, and that is possibly making them vulnerable to all these complications. But these modified 2-stage procedures also, we had 15% problem in these cases. And then we moved again back to the 3-stage procedures, particularly the patient has a long-term steroid therapy in their management. So I would suggest that if the patient has long-term steroid therapy, and we have seen that infliximab, I think the monoclonal antibodies or the biologicals actually not harming so much as the steroids. And that has been proved by the studies also, that except only one biological, the other biologicals do not have any problem with the anastomotic results. That is what my and second thing is, I just wanted to know, in the first stage we do stoma usually on the right side, that's the end stoma. And the second stage, when you do a stoma, invariably you have to do on the opposite side. And the patient has 2 stomal openings and skin openings. What is your practice, Dr. Deeksha?
So we almost always end up doing a diversion stoma on the right side itself. So the previous stoma trophine.
I think Deeksha is also facing problem because of the storm. So, Dr. Rawat, you want to add something to this discussion?
I think I've done single stage a few times when I was in UK, but in UK we will get the patients quite early. In the way gastroenterologists will refer the patient very early. But here, by the time you get a reference, you only do 2-stage or 3-stage. And like Deeksha has mentioned, that a patient is stable, not on steroid. My main thing is I always look at albumin, not on steroids. Patient is fit, then I will do 2-stage. Otherwise, somebody on steroid, I won't do 2-stage. Somebody who's got a quite an inflamed colon, colonoscopy showing pancolitis, patient is passing, a lot of blood in the stool. Those kind of things, I think it's safer to go for 3 stages. That's what my thing is. But here also, suppose if somebody patient is fit, then 2-stage. I have done 1 single stage here. That is the only one. I normally do 2 and 3-stage.
What about FAP?
FAP also, what I do, sir, is in the 2-stage, what I will do is I will fire the stapler at a very low end and do the covering ileostomy, and then I'll make a pouch and then do it. Uh, some of the patient who had a cancer, I I know some of the surgeons will do two stage, but I normally because what happened is difficult to say what kind of cancer is it, whether it's T3 and above, whether the lymph node is present. You don't want to subject the patient having a pouch and then receiving a chemotherapy. So I'm bit of a uh, uh, do in the way that I'm slightly reluctant till I get a final biopsy, and then I will make a pouch.
Dr. Shastri,
I,
have you done or would you do a single stage either in UC or in FAP?
No, neither. I have always done either 2 or 3. Never a single stage.
I think the message is reasonably.
Extensions, what
Yes,
Dr.
Vaibhav, please come in.
Just an extension of what Dr. Rawat told, sir, because whatever literature we read is from Western world. And the patient profile, what sir mentioned in crux, the patient profile of Indian population is very different from what the literature we are reading. So in our scenarios, we need to err on 2 or 3 stage procedures more often, similar to that.
Yeah, at SCPGI also, and I think this is the experience of everybody else. Although all textbooks say that steroids should not be used for maintenance of remission, they should be used only for induction of remission. But somehow a large number of gastroenterologists continue these patients on steroids. So that itself makes a one stage definitely a no-no.
So, because with all these risk factors, doing one stage is very challenging thing.
Yeah. So I would agree with what both Dr. Shastri and Dr. Rawat said, that for UC, one stage will be very, very rare. For FAP, it may be slightly more, but even in FAP, the more conservative surgeons would probably do a 2 stage, which means create a pouch and do a covering stoma. And once everything is all right, then close the stoma.
Isn't it interesting? The topic is single stage versus 2 stages, whereas the discussion is boiled down to 2 stage versus 3 stage. I think that shows the mood of the senior people here.
I have done single stage. But in the current scenario, the kind of patient you get, it's I won't do it. I won't do single stage. Very, very rarely. Like in UK, I've done single stage in FAP. I've done in ulcerative colitis also, but they are like elective, well-preserved patient,
Yes.
and they know the risk also, because you tell them all the risk, they accept the risk. I always tell them the risk of leak is about 10%, 5 to 10%. You will have a pouch failure, all those kind of things. If they accept, that's fine. But in some of the centers, they are doing single stage, but they are selecting the patients very cautiously, very cautiously.